Okay, let's get started. I'm Anthony Nappy, the nurse liaison for the Virginia Impact Project, which is a VDH-funded initiative to address infection control, preparedness, and congregate facilities across the state. I'm going to hand things off to our medical director, Dr. Laurie Archibald-Pannoni, and she'll get things started. Thank you, everyone, for attending.
Thanks so much, Anthony. It's great to have you all joining us today for our second session of our Project Echo series for Virginia Impact. As Anthony said, I'm Laurie Archibald-Pannoni. I am a geriatric physician here at the University of Virginia and serve as medical director for Virginia Impact. We are very excited to have with us today Elizabeth Gochenour. Liz Gochenour, who has been a nurse for over 20 years, is a nurse practitioner and a wound care specialist here at UVA, is a phenomenal clinician and a wonderful friend to have in a pandemic. And we're so excited to hear both her insights on wound care as well as how infection control and telehealth can be incorporated into that practice. So with that, I will also welcome everyone to ask questions as we go. We really want this to be a discussion as we move forward. So whether it's putting questions into the chat or if questions come up along the way, just let us know and we'll work to get those answered for you. So with that, I will turn it over to Ms. Gochenour to take us forward.
All right, well, thanks everybody for showing up today. I'm Liz Gochenour. So I've been at UVA for, gosh, I just had my 25th anniversary at UVA and I'm going to hit 26 years here in September. I got my NP in 2012 here at the University of Virginia. And so my background is I was an ICU nurse and a burn nurse for lots of years here in the surgical trauma ICU and the surgical trauma burn ICU. And then after I finished my NP, I transitioned on the inpatient wound team. And then presently, because of COVID and different things that have happened in the last few years, I now have clinic 4 days a week. I'm primarily at Zion's Crossroads, but I'm here in the main hospital in digestive health on Wednesdays for an ostomy clinic. But I still see some overflow of wound patients because I found out that jaunt is a primarily transportation for some of my patients, and jaunt does not go to Zion's yet. So I'm trying to figure out if I can help make that happen. So if, public transportation is their only way and they can only get to the main hospital, then I'm trying to accommodate wherever I can. So anywho, so right now I've got my ostomy clinic on Wednesdays, then I'm in wound clinic Tuesday, Thursday, Friday out at Zion's, and I do telehealth on Tuesday mornings. So that's been good. And I'll kind of touch more on that in a little bit, but what I found during COVID was it's really, wound care is a little bit challenging to do telehealth because there's so many things that you need that aren't just visual. So I really partnered with my home health nurses and tried to coordinate if I had home health in place or if the patient had home health in place to try to do the telehealth visit when home health was in the home. So I had more of an expert set of eyes that could help me with measurements, odor, color, drainage, that sort of thing. And it worked out pretty well. And partnering with, not just Continuum, but Interim, Amedisys. I mean, all the home health agencies in Virginia have been really great to work with. So let's see here. So let's start our little talk here. So basically our objectives today, I want to talk about, what makes up the skin, different types of wounds, what are our phases of wound healing, recognize factors that help optimize wound healing, identify factors that will negatively impact a person's ability to heal, and kind of discuss how telehealth has impacted this specialty. So basically we'll start off with your epidermis. Skin's our largest organ. I think the most important one, but heart and brain are important too. So anyway, your skin helps regulate your temperature. It helps you with holding on to fluids. Your epidermis is, the epithelium, your sweat glands. You've got nerves. It rests. The outer layer sheds. My little slide here, it covered up my words, but it sheds like in about 2 weeks, you'll grow all new skin. So, a partial thickness wound will heal fairly quickly. I always thought, when I got my burn patients, you would see that partial thickness burn and it would be all shiny and red, but you could see the hair growing through the burn. And that was always a good sign. And if it, as much as you hate for people to be in pain, if they had sensation, that was a good sign that, it wasn't quite so deep and you didn't have damage to the nerves there. Your dermis, so your next layer is about 3 millimeters thick. It contains the roots of the hair, your sebaceous and sweat glands, receptors, and blood vessels. Also compose some collagen, and that is where your strength, your elastin come into play. When you're dealing with pressure injuries, I don't know if most folks know that, once it's completely healed, it's only ever 80% as strong as it once was. So that area will always be at risk. So you have to kind of baby it and keep close tabs on it because it has really a high risk of breaking back down. So when you're looking at wounds, we talk about pressure sores and those you stage. But you only stage pressure sores. I once had someone tell me they had a stage 4 belly wound and like, no, it's full thickness. So if you have, partial thickness would be like a skin tear. Anything with depth is more of a full thickness. So on the slide, you can see you got your partial thickness, which is at the top, and that's a skin tear. And then the bottom wound, you've got more depth and it's down into the subcutaneous tissue and muscle, and that's deeper. All right, so skin tears, which you see, we have that kind of runs rampant with our elderly population. Nutrition is an issue sometimes, and they just are really fragile. So, when you pull them over and things like that, and, you can get shearing injuries, skin tears, they can just bang their arm on a side rail or the car door, and it just is really damaging to their skin. Moisture associated skin damage is something else we see quite a bit with incontinence, trying to manage keeping them clean and dry, minimizing layers. A lot of times in hospital settings, you'll see them on several layers of sheets and cushions, pads, chucks, diapers, pants. And so all that holds in heat. And so the minimizing your layers is helpful to get some air in there so things can kind of breathe. I like my zinc creams a lot. Greer's goo is hard to get these days if you're familiar with Greer's goo. So you can actually just order the 3 separate ingredients, and then I have them just put equal parts in their palm, or even get a Ziploc or Tupperware container and put everything in there and mix it all together. And then they have, you have to kind of compound it yourself because a lot of the pharmacies don't like to compound anymore. And so you kind of have to, be a little creative. And if you have some uninsured folks, then a good, a zinc cream like Desitin and some hydrocortisone and a good jock itch or other antifungal that you can get over the counter works fairly decent. So you can kind of make your own antifungal with a hydrocortisone and a zinc based ointment. And then you have your kind of own knockoff Greer's goo. Throw in some lidocaine and you're just cooking with gas at that point. Fungus, we get a lot of under the breast folds, the pannus folds, and sometimes I get a little creative. We have this fancy stuff called Intradry in the hospital. That's a textile that has silver in it, and it is a moisture wicking fabric, but it's hard to get. And like I said, some folks don't have insurance, so I'll have them take a t-shirt and cut it into strips, or a pillowcase that's cotton and cut it into strips or not, depending on the size of the skin fold, and use that so that the skin folds don't rub on each other. The cotton helps wick moisture away. And that works pretty good. We also have, so not only partial thickness, full thickness, you have your surgical wounds. So I utilize wound vacs at some points with surgical wounds, especially if you are trying to get some rapid granulation. Now that I guess the patent has expired with KCI, you can get a wound vac. I think it's neat that Medela makes a wound vac because, there are breast pump people. 3M is now KCI. You've got Medela. There's and a ton more. I just returned from conference and there was about 7 or 8 different wound vac options at conference. So there's lots of different things. And so sometimes they'll come to clinic with the wound vac on and it's not a KCI vac. And if they didn't bring supplies with them, I've gotten some calls like, well, what do I do if they come into clinic and they have a wound vac and I need to take it off, but I don't have anything to put back on? Then we can help, that's where we utilize our home health resources, and you can do a damp gauze packing in the clinic, send them back home, and then home health will come the next day and put the vac back on. I've even had folks come to clinic. I'm like, ooh, this is ready for a wound vac. So put the order in, order the vac, it gets delivered to their house, and home health can initiate it. Or they can come back to clinic for initiation, but sometimes they're far away. So, home health has been such a valuable resource in all of the past couple of years. I have to give them a lot of credit, because you have to be expert in everything when you're a home health nurse. So they've been doing a great job, and short staffed like the rest of us too. So they've been doing great. Talked a little bit about pressure sores, very expensive to treat, better to prevent. Can cost anywhere from $20,000 to $150,000, depending on the depth, severity, and how long it takes to treat. So it's always better to prevent if we can. So regardless of our wound type, we need common ingredients to get them to heal. And this is often coupled with other influencing factors, like, are they smokers? How are their blood sugars? One takeaway from conference this year was, I always try to look at, when I finish conference, what can I bring back and institute immediately that's not going to cost anything? Because, sometimes they take longer to put into place. And there was a big push for, checking on nutrition markers, and homocysteine levels was one thing that they talked about. So a homocysteine level will give us a gauge for, where are their B vitamins, their B6, B12, and folate. And if they have an elevated homocysteine level, then usually they're deficient in those, and that can impede your wound healing. And I'm not a chemistry major by any means. And when I looked it up and tried to explain that something with the homocysteine levels and being deficient in B6, B12, and folate causes an abnormality with the nitrous oxide in the wound that delays wound healing. And I'm sure that you can Google it and get a much better explanation. And actually, I've probably sent about 10 labs for homocysteine level, and I had my first elevated homocysteine level today. So I called her and told her to start taking a multivitamin with B6, B12, and folate. The one that it seemed like popped up in most of my searches, there's a Centrum Silver for 50 and older women that I told her might be a good choice for her, but really it doesn't matter. There's a gazillion types of multivitamins on the market that are wonderful. They even had a couple that were like homocysteine plus or stress something B12, and they all looked like they would be good too. But just kind of looking at the cost, I know there's a couple generics as well. Alrighty, so our phases of wound healing, you have your hemostasis, inflammatory, proliferative, and maturation phases. Hemostasis is basically your onset of injury. So that's, you've had trauma and it's bleeding, and you want to stop the bleeding and stop the trauma. That's when your white blood cells come into play, your platelets. So here this is your rescue 911 step. You want to stop the bleeding and get that stable. And then you have your inflammation phase. And that's where your bacteria gets destroyed, debris gets removed, your white blood cells, they arrive, they can continue clearing debris. This can last about a week, and it's associated with your edema, your erythema, the heat, the pain. A lot of times when I'm seeing a wound, and it's good to see wounds weekly to get weekly debridements to, clear the debris. I use this analogy a lot, is if a hurricane hits your house, you have to clear the lot before you can build a new house. So you have to clear all that debris out of the way before a wound will heal. So if you've got all this gunk and slough and necrotic tissue in a wound, it's not going to heal. And then I also try to utilize, I keep a tube of silver nitrate sticks on me almost all the time because it's a chemical cautery, and I use it around the wound edges. And what it does is basically you're cauterizing the wound and kind of throwing it back into the inflammatory phase, kind of resetting your wound healing cycle. So if I've got a wound that's stalled, I'll just touch some silver nitrate around the edges to get it to kind of go back into that inflammatory phase, and it resets, or in my mind, it resets. And I do see good results from that. So, I tell folks, don't be too hard on yourselves. if you go to 6 people for one wound, you're going to get 6 different things. There's really not a lot you're going to do to break it. And a lot of it is kind of trial and error and experience and kind of figuring out what works for that person too. What works good for one person may not necessarily work for someone else. But like when we continue going through those common ingredients, moisture management and, clean, moist wound healing environment are going to be essential. All right, so after your inflammation phase, you get your proliferative phase, and there's 3 phases in that. You want to see the wound edges contracting. You want to see reepithelialization. It can last for up to 24 days. And the goal is to, if you've got a deep wound, you want the granulation tissue to fill it in, to see those wounds contract. And wounds always heal from the outside in. I actually had a really sweet lady come in a few weeks ago. She had a bilateral mastectomy, and she was still getting radiation, and she still had, she was getting chemotherapy, and she had a huge lesion on her chest. And it was just really painful and draining a ton. So it was a little overwhelming to look at first. So I kind of broke it down into I took some Emla cream, the 4% lidocaine, and I just numbed the edges. I went all the way around the edges, and I used a curette after I let that sit for about 15 minutes. And I just started debriding just the wound edges, because that's what's going to heal first. If I don't debride the center the first time, it wasn't going to make or break the wound, because that's the last thing that's going to heal, was the center. So I cleaned it up good, and I debrided just the edges. And I think she was just doing ABDs and nothing else on the wounds just when I saw her. So I used Xeroform. So Xeroform, somebody put me on to Xeroform. It's something that's not very expensive. We have a lot of it. The bismuth in the Xeroform is a good antibacterial. The Vaseline gauze is a good moist wound healing material. And the gauze is a wide weave. So if there's any drainage, it passes through the gauze. So it won't pool on the wound. So I use Xeroform, and it's not too painful. And so it comes in a big sheet. So I could cover the whole thing with Xeroform, and she could change it daily after she took a shower. And I had her come in once a week, and we just debride the edges, and the edges got smaller and smaller until it was miraculous to see it get smaller. I mean, it was every week I had skin buds and I had new epithelial tissue, and it got to where I was using 5 pieces of Xeroform, and then I was using 3 pieces of Xeroform, and I was using like 3 ABDs, but now I'm using 2 ABDs. And it got to where it was just kind of the center part. And she was super happy because it wasn't draining. It wasn't painful as much. And she didn't have to use half a roll of tape on her poor body every time she changed dressing. So that was good. And sometimes you just have to kind of break it down to where just take little sections on the outside, and then just see them more frequently. And that seems to work pretty good. All right, so the last phase is your maturation phase, and that's where the new tissue gains strength and flexibility. Only 80% of that pre-injury strength, and this can last up to 2 years. All right, so what kind of things factor into our wound healing? Your age, of course. Young folks, well-nourished folks heal so much better and quicker. Body type. When you have someone who's obese or malnourished, both ends of the spectrum, you get your challenges. And obesity does not necessarily mean well-nourished. You want to check labs. Usually if I suspect osteomyelitis, or I can probe to bone on a wound, then I suspect, or I assume osteomyelitis until an MRI tells me differently. So you'd want to get an x-ray. I know the literature says get an x-ray and then an MRI, but sometimes I just get the MRI. It kind of depends on the patient and how strongly I suspect it's osteo. Their vascular status. I'm working on trying to be able to get ABIs in clinic. Right now I have to order ABIs through radiology, and it can take a week or 2. And if they need compression, you really need to know the ABI, because if their vascular status is really poor, then you wouldn't want to add compression. You could actually cause an ischemic injury. So Ideally, you want to, see what your vascular status is on someone with edema and venous stasis ulcers before you wrap them up. Fortunately, I've been able to like see them more frequent enough where if I had to wrap them up in the meantime, I could watch them close enough to make sure that they don't have any kind of ischemic problems in their toes. Infection, of course, that plays along with the osteomyelitis and dehydration, edema. A lot of my, venous stasis ulcers, if you have +3 pitting edema and they are weeping to beat the band, they're not going to heal until we can get that edema managed. And, that fluid is taking the path of least resistance, and it is just soaking wraps, dressings, sheets, pants, everything. And you're officially a wound nurse when you're in the food line. You're like looking down, you're like, oh yeah, they need some leg wraps. So anywho, their medical history, and of course their medications. I've had a couple folks in the last 6 months that fell, and because they were on Coumadin, they like whacked their shin, and then they had this huge hematoma that I've had to kind of evacuate because it swelled up, got red, and then like these little ulcerations developed, and then they started just kind of oozing on their own. But you just knew that there was, here we are 2-3 months post-injury, and now we're getting an odor, and yeah, so I don't know is that we could have done anything differently, because you're hoping that hematoma will reabsorb and kind of go away. It just kind of depends on how big it is. But I had one gentleman, I had to actually IND the wound, get the hematoma out, and we wound vacked it to get it to close, but it almost went down to bone. It was like 4 centimeters deep. It was pretty impressive. Not in a good way, impressive, but. Alrighty, so how do wounds heal? We have, they either hear about primary intention, which is not usually what I see. That's what you just, as soon as you're close, and they go about their business and yay. Usually what I see is the secondary intention, where either a surgical wound is dehisced, or you've got venous stasis ulcer, diabetic foot ulcer. So you have this open wound that you need to heal from the inside out, get it to fill in, and then re-epithelialize, or, or scar down. This kind of plays a part into our telemedicine talk too. When you're assessing a wound, you want to look at the appearance, the color, the peri-wound, the drainage. How much is the drainage? Does the drainage have an odor? Does the drainage have a color? Is it painful? And then you always measure your length and width and depth. And your length is always head to toe. Width is always side to side, and depth, you want to go at the longest, widest, and deepest part. And this is another caveat of wound care, is when you have a different home health nurse or a different nurse measuring it every week, you're going to get slightly different measurements. So sometimes it's hard. They've got a lot of new software that's expensive that they had at conference, where you take a picture of a wound and it gives you the measurements. So you don't have to use a ruler, and then you're like introducing something that could contaminate, this piece of paper that has numbers on the side. Or I use the little Q-tips that we have here, have a little ruler on the side of it. So I always have pockets of Q-tips. And then now I've got, in my bathroom pockets Q-tips, and in the dresser Q-tips, and I've got Q-tips everywhere. But so you want to kind of, if you need to kind of keep in your mind where you're measuring, try to measure the deepest part, and try to be consistent as to the same place every time, looking for tunneling or undermining. And the difference is, a tunnel is just like it sounds. You have like a track or a tunnel, but undermining is kind of like if you can take the Q-tip in and sweep it back and forth like an overhang, that's more undermining. Where a tunnel is like you've got like a tunnel, a track or cavity there. Let's see. So other interventions would be, you've got, if you have that 3+ pitting edema, do they need a diuretic? Sometimes I'll call their cardiologist, because they're already on, Bumex twice a day, and say, hey, what do you feel if we did, for the next week, they took Bumex 3 times a day, or I kind of reach out to my colleagues. Because sometimes these people are very complicated. Using compression, nutrition. Are they getting protein? It takes 60 grams of protein a day just to maintain your muscle mass. So you throw a wound in there and, you can get specific, calculations from a nutritionist, but I try to add another 20 grams or so for the wound. So we shoot for, 80, 90 grams of protein a day. And sometimes, they're not getting anywhere near that. I actually had a lady this week. I'm like, what did you have for breakfast? She said an egg and toast. What was for lunch? A handful of nuts. And then dinner was a salad. I'm like, did you have cheese or anything on the salad that would be a protein? And not really. So think about, just if you just include a protein source with each meal, a yogurt, a cheese, eggs, peanut butter, meat, some sort of milk like substance, ice cream. Their A1C, we usually keep track of that. Are they diabetic? What was their last A1C? If it's 7.5 or higher, wounds are very slow to heal. So for optimal wound healing, try to get it below that 7.5 mark. Antibiotics, if you feel like there's a bacterial burden to the wound, or if it has a cellulitis in the peri-wound. Another thing they talked about in conference this year was not just cleaning the wound when they come into clinic, but to clean about a 2-3 inch margin around the wound. And in fact, several of my colleagues in the wound clinic community said they would just like scrub them with chlorhexidine, like Hibiclens from the knee down. If they had a foot wound, they just cleaned the whole extremity. They would scrub it down and, really clean, because if there's bacteria and normal flora that could contaminate the wound, then as soon as you start debriding it, and then you're going to get other things in. So the more area around the wound you can clean before you start to debride, the better. Sometimes I will culture a wound, but sometimes it's hard to culture a wound because of the normal flora that's found, and it's easy to get contaminated. And I've even had some folks come in and say, oh, my doctor cultured my wound last week and it grew a ton of stuff. And I'm like, well, what did they clean it with before they cultured it? Oh, well, they didn't clean it. So, at least some saline to rinse it off. And then, when you swab, you want to just kind of use the Q-tip until you get some exudate. But the better you clean the wound bed and around it, the better you'll get results as far as the culture. Oxygen, we've got hyperbarics here. If we need to look into doing some hyperbaric oxygen, they actually have topical oxygen now, which is like high flow oxygen to the wound. And in Virginia, Medicare is not covering that yet, but the VA is reimbursing it. So I'm scouring the country for the state for veterans that I actually enrolled my very first patient in topical oxygen last week. So keep our fingers crossed. It's really neat. It's this like clear plastic boot that they put on. It fills up with oxygen and provides some compression, and it permeates the dressing. So unless you have an airtight dressing, you don't even need to take the dressing off, and you have them wear it for like 30 minutes a day. So we'll see. I'll keep you posted. I'm kind of excited about the topical oxygen because sometimes it's hard to get people, meeting the criteria for hyperbarics. They have to be diabetic. They have to have had osteo. There's lots of different criteria. And I actually have one gentleman that's getting HBO right now. That's one of my diabetic heel wounds. And from the time I put the consult in to the time he took his first dive was almost 2 months. So it just seems like everything takes forever. So anyway, and then there's smoking status. The smoking causes vasoconstriction. I've still yet to have, I had a 20-something come in. I'm like, do you smoke? No, but I vape. And honestly, I don't know what the conversion is from smoking to vaping. So I'm going to have to kind of look that up and figure out, like, how do you convert? Like, is it like a pack per day? I'm not sure how the conversion from cigarettes to vaping happens, but I'll try to figure that out maybe before I speak to you guys again. And then mobility. Of course, ambulation helps with venous return, also helps prevent pressure injuries because they're moving around more. So the more you can do that, the better. I actually had this cutest little elderly couple, and he just loved her and he just doted on her, but she had a pressure injury, and he went on Amazon and found an alternating pressure surface that he found on Amazon for $80 and ordered it to bring home to put on their bed. And he just was cute as a button, and it's doing much better. And we're vacuing it now, and home health is working with them, and it's a little bit less than half the size that when we started. So it's heading the right direction. But he is cute as a button, and you can get almost anything on Amazon. Okay, so our goals of care for topical wound care: to protect the wound bed, provide thermal insulation, maintain that moist wound surface. If it's deep, you pack it. If it's shallow, you cover it. So you want to fill in the dead space. If there's tracks and tunnels, you want to fill those in. Remove necrotic tissue. And sometimes I see folks weekly. Sometimes I've seen folks more than once a week. You want to control that bioburden of bacteria in the wound, and they should be cleaned with each dressing change. Soap, don't underestimate the power of soap and water. I used to be a big dial fan, but new research shows that wounds like to heal better when the pH is about 3.5, and baby shampoo is kind of the one that kind of checks that box. Sometimes I'll use Dakin's. Dakin's pH is 13. So I try not to use Dakin's for more than 2-3 weeks if I can help it, just because it does great to kill bacteria, but it also kind of impacts new granulation tissue. Vash, the hypochlorous acid, pH is about 3.5, so it does a little better, and you can use it longer term. Don't have to worry so much about a cutoff date. And it works more by bursting the cell wall. And so you don't really get antibiotic resistance. It's not an antibiotic. It works by destroying the cell wall and destroying the bacteria that way. And it has about a 30-second kill time for most of your bacteria. So it works pretty quickly. So the order usually will say, let it sit on a wound for, a couple minutes. But usually the studies that I've seen has been like between 30 seconds and a minute. Usually if it needs killing, it's dead. So yay for Vash. Okay, so one big thing they talked about this year at conference was biofilms. Biofilms are just basically colonies of bacteria that become attached to your wound in as little as 24 hours and almost make like a dome, like a force field. And you can't penetrate that, and it really impacts your wound healing. And ways that you get rid of the biofilms are really debridement, because you scrape it off. And there are a few ointments and things that can really affect the biofilm. But the healing potential of a chronic wound really is decreased when you have these biofilms. And they have found that most all wounds will end up with a biofilm at some point, because it promotes that chronic inflammatory state that impacts wound healing and prevents that wound healing from happening. Most open wounds will contain microorganisms from just the patient's own flora. And usually your immune system will help keep those in check. But if they attach to the wound bed and then the wound biofilm starts to form, a well-established biofilm will be resistant to the destruction of the host immune system and the antimicrobials. So if you have a wound that you're doing good wound care for, but it's not healing, then you have to really suspect that biofilms are in play. And kind of preventing them and treating them are really essential, that we found to treating these chronic wounds. And one of the things that I really was frustrated with is because when I started as a wound provider, I was only having clinic like once a week. And I had so many patients that I could not see once a week, and they really needed to be seen to have their wounds debrided and assessed more frequently. And it was really frustrating. So then that was when telehealth came into play. So at least I could at least lay eyes on it. If I had a new consult and they're like, they need to be seen now, if you wait a month to see a foot wound, it could be amputation versus not. So really they have to be seen. So telehealth really helped with at least let me lay eyes on it. Do I need to start an antibiotic now? And the time it takes me to get them into the clinic, be seen in person, so we don't end up in trouble. Yeah. Okay. So what do we know about biofilms? Bacteria can attach within minutes. Bacteria can form the microcolonies within 2 to 4 hours. They can be resistant to therapies within 6 to 12 hours, and the biofilms can be mature within 2 to 4 days. And once you disrupt them and scrape them off, they can reform within 24 hours if they're not treated. So how do you know if you have biofilm? Because you can't really see them. Sometimes I've seen like the wounds will be kind of shiny. You might scrape them and get like this jelly, like gelatinous slough. It's easily removed with like either coarse gauze or a washcloth and soap and water, or we've got curettes and scalpels and things that we can really get in there. I myself have used like a saline bottle and taken a 19 gauge needle and poke 3 holes and then squeeze the bottle, and I'm not sure the like pressure per square inch, but it's enough where I'm able to like use the saline to really like irrigate the slough off. And sometimes that's not as painful for the patient, especially when you're trying to do this in the clinic. And yes, it makes a mess, and I get fussed at all the time for making a mess. But I put down a drop cloth of chucks and we're usually okay. You might see for biofilms an increase in the exudate, increase in pain or odor, and this could be a sign of a secondary infection. You might see as soon as you stop the antibiotics, the symptoms come right back. So the antibiotics will like temper everything. But you know, I've had a lady call last week. She's like, it looked a lot better, but I stopped taking my antibiotic yesterday, and now I have an odor again, or now I have increased drainage again. So I'm like, okay, well then let's get you in so we can debride it or see what's going on. So how do we get rid of it? So frequent debridements to remove, disrupt, and prevent the biofilms. Dressing selection, negative pressure, the wound vac is really great to remove bacteria. And then when you change the dressing and pull the foam off, usually it will debride, because you'll see, you know, as soon as you take that black foam out, it'll start to bleed, and bleeding is good most of the time, means good blood flow. Antiseptics like your hypochlorous acid, cadexamer iodine, like iodosorb, it's that like kind of rusty colored gel. You can use that. They actually have a new sustained release iodine foam dressing that I've been having good success with. It works kind of like hydropheric blue, where it's, you put it on a wound, it can stay on for like up to a week, but it's the iodine is, it just, think for at least 72 hours to 3 to 4 days, it'll slowly release the iodine into the wound bed and kill bacteria. And I believe that cadexamer iodine is one of the few things that will actually penetrate through the biofilm. I think, you know, the silvers, the methylene blues, and they keep the bacteria down in the wound bed to help keep them from forming. But if a biofilm is actually there, I believe that iodine is the most effective thing to kind of penetrate and break through it. Bismuth, and that is what is in zero form. My favorite thing ever, is still being researched, but I think just from the clinical picture that I get with my zero form, I think that it does do a good job. Maggot debridement is also shown to be effective. Of course, I can't do that in the outpatient setting, but any of my inpatient friends and colleagues, if you suspect biofilm, maggots are great and awesome. To help debride when you are not a surgical candidate, or if, you know, surgery is contraindicated. You know, I've always liked to say that if I had someone, heck, if you come in for renal failure, but you have a wound that needs debriding, well, while you're here, we might as well, you know, optimize that and put some biodebridement, use our biodebridement friends. All righty, so treatment options that we have. So, you know, I talked a little bit about wounds. Are kind of like Goldilocks. They don't like to be too wet or too dry. They, you know, so if it's a dry wound, then you want to hydrate it with a hydrogel or some kind of hydrocolloid. And hydrocolloids are good for dry to light exudate. If you have a wound that's draining a lot, then you want to look into your alginates, and those are made from seaweed. Your hydrofibers, like your Aquacel Silver, or we've got, I think here we are using the Exudry with and without silver. Foam dressings for moderate to high exudate, and then of course negative pressure therapy for heavy exudate. But one thing that I think is a misinterpretation is I've had a couple of people say, well, I can't put a wound vac on it because it's not draining very much. You can still use a wound vac even if it's not draining a lot, because it also helps improve perfusion. It helps stimulate granulation tissue. And if it has a lot of exudate, it manages that and pulls it out of the wound. But just because you don't have high exudate doesn't mean you can't use a wound vac. You just won't have a lot in the canister. But you can still do it, and you should still see, you know, you should hopefully still see some robust granulation tissue. And then our silver dressing. So you can get your alginates and your hydrofibers with and without silver. All right. So evidence-based practice for goals of wound care, I've always been, you know, does it improve outcomes, and is it cost effective? sometimes the $200 thing is not the best thing, but sometimes it is. But I try to be a good steward of my resources because, I want to make sure that, right now I'm very blessed that I can, if I really feel strongly that I need something in clinic, that they let me order it and I can stock it and have it to use for my patients and order it for them. But I don't want to take advantage. So, and there's a lot of nuances as far as outpatient wound care that I never knew, like Medicare and a lot of my insurances, because they follow Medicare's guidelines. And I think it changed this year that if I have a wound, even though it's draining moderate to heavy amounts, if I order a foam like a Hydrofera Blue or the sustained release iodine foam, if they categorize it as a foam, then I can't order a Mepilex or an Aquacel foam to go over top of it because that's 2 foams. So I have to be a little creative and know what is that called, and will insurance let me order both, or do I have to kind of figure out creative ways to if I need that foam because it's draining a lot, then I just give them zero form from clinic and let them order the foam through their insurance, or try to figure out, what's the best way so I can get them what they need, and still, get them without them having to spend, their rent money or their, electric bill on dressing supplies, because dressing supplies are really, really expensive. And a lot of folks just go to Walmart and get gauze. And if you think about, okay, well, it's $3 or $4, but if you're going through 10 gauze a day, then, and you're spending 50 to 70, 80, $100 a month on dressing supplies. I mean, that adds up, especially if you're on a fixed income. And tape is always something that everybody wants. I will put out for my Charlottesville colleagues, there's a place right across from the Walmart on 29 called All Blessings Flow. And they kind of recycle and upcycle wound supplies and things, and hospital beds and bedside commodes and Hoyer lifts and all kinds of stuff. And if you need it, you can reach out to them. And if they have it, they'll just give it to you. And they also have wound supplies. So if and ostomy supplies. So for folks that had a wound and now it's healed, but they were able to get things through their insurance delivered to their home, and now they have baskets full of 4x4s, they can take them to All Blessings Flow and they'll find them a home. So that's been a good blessing to have for the community for ostomy supplies and for wound supplies. And they usually have the heart-shaped Mepilex for sacrums and the squares, and they'll, they might only give you 4 or 5 a week, but you can go back every week and touch base with them. But I've had folks get the Rascal scooters, the knee rollators, the walkers, and canes. And if they have it and you need it, then they help get that for you. So anyhow, all righty. And so let's talk a little bit about telehealth, and it's good to see David. So back in 2015, the inpatient wound team started working with telehealth. And we did a pilot with Dogwood Village in Orange. And we started, they would just roll the WOW into the room, and we would do the assessment in the bed with the wound care nurse in the room and the aide, and we would roll them and take, they could send me pictures and we would measure and do stuff. And we could do that weekly or monthly or whatever we needed. We also did the health wagon in Wise. And we did some Department of Corrections. I always wanted a jacket that said WOC and the DOC, but I haven't gotten that yet. But anywho, so we really, I felt like we did a lot of good jobs with that. A couple of my colleagues got a grant, and we got a laptop or 2, and we were able to reach out to our colleagues with like Coloplast, Hollister, and Convatec, and they sent supplies to our remote clinics so that if a patient came in with ostomy needs, then they would have some basic ostomy supplies in clinic. And then we could do some telehealth that way. Just kind of giving them a list of like basic wound supplies, basic ostomy things, so they would have them there. So if we saw something, at that time, it was the way they did telehealth is we went downstairs by the higher grounds. They had an office. We went into like an exam room that had a computer, and the patient was in an exam room at the health wagon or wherever. And then we would talk to them like we were in an office visit kind of setting. And now we've gotten so much more options as far as telehealth to do instead of having to be kind of in that location. But we also used a lot. We got, I think, with that grant, we made a lot of like pamphlets on telehealth, and so we could advertise that we were doing this. And like I said, it was really challenging to do telehealth with wound care because you have to really most of the time see the wound, smell the wound, touch it and poke at it and see what it does. So having the home health nurse has been really valuable to my setting. And I believe that during COVID, Continuum actually lost their home or their wound care nurse. And so I was trying to help out in that respect too. So, it's not good for your sacral wound to be on a stretcher for 8 hours. I would see my sacral wounds deteriorate. They would look good, but then they come see me in clinic once a month and they get home and I'm like, what the heck happened? Well, they spent 8 hours on a stretcher driving down 81. And that just was not good for our sacral wounds. So to do them in the home setting turned out to be better for the wound whenever we could do that. And thankfully then, because of the nature of Medicare and wound supplies, if I have a patient that needs wound supplies and I can order them and that their insurance cover them, Medicare requires wound care measurements once a month in order for them to cover it. So I'd have to see them once a month and have some sort of note to send in for the insurance so they would cover their wound supplies. So thankfully with COVID and the legislative changes and how that we could bill, they counted the telehealth visit as a visit so that I could get wound supplies for them and they didn't necessarily have to come in, which was better for the wound. And patients were really great about sending me pictures through my chart. That's been a blessing. And home health nurses can take pictures and I can get them that way as well. Not to mention the cost of ambulance transport. I remember when we worked with David initially, and we talked about even if we could see a few Medicaid patients monthly, the cost of Medicaid cabs and Medicaid ambulances from like Wise and Grundy and like these far off places in Virginia that were really remote. Not to mention, I think it's not good to ride in a car for 5 hours, blood clots and, stuff can happen at 5 hours of immobility in a car with a patient who's got multiple medical issues. It was amazing just talking about being a good steward of resources, the money you could save by doing telehealth for a normal post-op visit. If you didn't need to do suture removal or staple removal, if you're just, hey, how you feeling? How you, it's just a conversation and you don't have to travel 5 hours in a car or on a stretcher, then it's better to not have to do that. All right, so any questions up to now? I have a couple case studies of people that healed, yay, and then we'll be done. But if you have any, we can stop here just briefly if there's any questions.
Liz, that's interesting. So kind of another area of focus with respect to our initiative impact is telehealth in congregate facilities. And you mentioned, the benefits that come to my mind. You mentioned with respect to, other than the clinical aspect of examining a wound via telehealth and having a nurse partner on the other side, did you find any other barriers from the standpoint of the facility that were common? Like, was there any internet capability issues, or was there any issues with respect to staff buy-in on that side of the telehealth connection?
No, I think so. A couple of challenges. So they had to be in the state of Virginia. So I had to have a couple of people drive to McDonald's and use their Wi-Fi, or Starbucks and use their Wi-Fi. And so depending on the type of visit, you can't really do that in your car. So that wasn't too bad. Those were more if it was a conversation to be had, or if I was doing ostomy teaching, I could do that telehealth pretty easily. And if I had to do that at a remote location, or if I had to get them out of West Virginia into Virginia at a free Wi-Fi location, then that didn't seem to be too much of a problem. The Department of Corrections has a few challenges. A couple of times they've like brought them to the infirmary or to the medical, and there's no one there with them. So it's kind of, a conversation, and they can show me their wound or ostomy. Supplies can be a challenge sometimes with the Department of Corrections because they are not allowed to have things with them. And so they have to come to medical. So I try to think of like, what can I do that could be a multi-day dressing, or it only needs to be changed like once every other day, if that's possible. Nothing that needs scissors or, or they would have to go and do that sort of thing. But really for the most part, the internet's been fine. Staff has always been really helpful and accommodating. And, I think if anything, the last couple of years have taught us to kind of roll with the punches and be flexible and creative. But I think, it's gone pretty well.
It's good. Thank you.
All right, well, let's do a couple case studies. So I laugh because, I told you I went to conference at the end of April, and, it's like the Hall of Miracles, every wound is healing and all, everything. Everybody's like, oh, look what I did and my wound healed. It's like all these happy things. And I wish it was that easy sometimes. But these are a couple of my success stories. So this lovely lady was 64-year-old, had a she's quite something. She's so funny. And she reminds, I always kind of joke because she also sells flags, the little garden flags. So she always comes with her bag of flags. See, who wants a flag. So I always joke like Sheldon from Big Bang Theory, fun with flags. But she had a venous stasis ulcer, and she had this wound for I think about 2 years, and they were talking about amputating her leg. That if it got deeper, and when I saw her, she had ligament exposed in the wound, and it was, I think, like 7 or 8 centimeters by 4 centimeters, and it was a good probably centimeter deep. But she's not a big lady, so that was down to some tendon. She had a history of low back pain, osteoporosis, gastroparesis, anemia. She's diabetic. And she had said the wound would get better and worse and better. And they were wrapping it with Uniboot so when I saw her, she had these bilateral lower extremities, had the chronic venous stasis, skin changes, and she had this wound. So this is what it looked like the first time I saw it. It was really shiny. I don't know if you can see, right there was the tendon. And so what I did was I continued the Uniboot because she still had some swelling and the venous stasis changes. I had her ABI, so I knew that I could do that because she had brought me the records from her other wound clinic. But they had used Hydropheric Blue in the past. They had used Aquacel Silver in the past. They had, I want to say they had maybe even done Meta Honey or Thera Honey in the past, and nothing had worked up to this point. It was just getting worse. So this was when I whipped out the iodine sustained release foam that I had got from conference last year. I thought, let's give that a whirl. So I had her, she's 2 hours away, and I said, I need you to come back every week. So she said, okay. And so we started that. And so this was on the 3rd of March. And then that was the 9th of March. It was 6x4. And then this was March the 16th. And then that was last week with just using the sustained release iodine. And funny enough, so her home health company, I called them because I was hoping that they would provide the sustained release iodine foam, and they won't because they said it was too expensive. So I just give it to her. And so she comes in every other week. I change it. And one piece of foam now, it's small enough where one piece of foam is 3 or 4 dressing changes because you can cut it into little pieces. And then I just send her home with the rest of it, and home health is changing it. She gets it changed twice a week. I change it once, they change it once. And then she comes back and sees me every 2 weeks. So I'm tickled pink that I'm hoping it's going to be healed soon. And she is tickled pink. And the dressing is this black dressing. She's like, I don't know what that black stuff is, but it's great. And I've told everybody, if they have a wound that won't heal, they need to come see you and get like, and she's killing me, but she's sweet. And she brought me a flag. So, there's that. So anyway, so now it's like 5x3. And I think, it's just, you can see on the edges, like the edges are contracting. It's filled in. It's a nice color. And the swelling is better. So she's very happy. All right. So that was my fun with flags lady. The next lady is this lady. She's 70. She has a host of problems. In stage kidney disease. She had this wound also for a couple of years, and plastic surgery was following it. And you can see they did a skin graft. So you can see that half of the wound is covered with the skin graft, and it kind of fell off the other half. So after plastics was like, there's nothing else we can do, go see Liz. I'm like, okay. So here we saw, and I'm like, okay. So looking at this wound, it had a lot of debris. So I took a curette and scraped all that crap off, all of the stuff off the edges. And I don't know if we can see. So if you see all these like bulgy granulation pieces. So hypergranulation is kind of what happens to a wound when it gets too wet. So you got this robust granulation tissue, but now your body's just working. It is like an overachiever. And you've got these mounds of granulation tissue all around the wound. But new skin is not going to go uphill. So you've got these like hypergranulation that's above the area or above the height of the surrounding skin, and it's not going to heal until we get that hypergranulation kind of beat back down. So that's where I use my silver nitrate, and I cauterize the edges. I had her come once a week, and every week we cauterize the edges. And we used Aquacel silver or another silver hydrofiber, whatever I had handy, to help absorb the exudate. The silver provided antibacterial properties. And then, so that was November. This was November the 17th. So from the 8th to the 17th, the difference in just treating the hypergranulation and getting the moisture under control. And then there was January. And so you can see it's still on the edges, and we still have lots of hypergranulation in the middle. So we cauterized that again. And then there was March the 2nd. And then that was last week. So I'm essentially calling that healed, even though it's kind of scabby, and told her just to come back if the scab falls off and it's not completely healed under there. But I think she, she was seen by plastics for a good year and a half, 2 years. And from November, December, January. So it took me 8 months, but she was happy. I'm happy she's happy. All right, and that's it. And then here in the slide is how to get your credit. And I appreciate you all.
Thank you, Liz. And yes, with the follow-up emails that I'll send out next week, we'll include this slide and information about how to get claim your continuing education credit. I thought that was a great bridge to the telehealth, Liz, and I appreciate that. One of the other, like I said, focus of Virginia Impact is telehealth and congregate facilities. And along with that email, we'll include kind of our initial survey just to kind of see where people's thoughts are with respect to telehealth and telemedicine and out in the community. And, part of our kind of overall assessment across the state will include seeing where people are with respect to that. So really appreciate that bridge to the topic of telehealth, Liz.
You're welcome. Thank you. It's been a joy to participate with this. Thanks for the invitation.
Yeah, thank you so much. I just want to echo, Anthony's thanks as well. This was wonderful to walk through both the successes that you've had and really the practical tips that you've given of how to kind of get these things done for our patients that are suffering so much. I think that, hearing your 3 holes in a saline bottle as an irrigation tool is phenomenal. Thinking about ways to both use technology, telehealth, yes, and people and simple interventions, I think is a wonderful way that we can all come together to really help our patients there. And so how to make, kind of a Greer's glue type thing and how to, make an irrigation tool with limited resources. I think that that's super beneficial to know. And I really appreciate you sharing those with us. So thanks so much. Well, with that, as Anthony said, we'll follow up with the emails, both for the CE credit codes as well as for future sessions. Our survey that we're sending out just to get a sense of people's experience and thoughts on telehealth in our facilities. And then we will not meet in July. We'll take that off, a little bit of a summer break, and then we'll all come back together in August to continue the series. So with that, thank you all for coming today. We greatly appreciate it. Thank you, Liz, for sharing so much with us. We've learned a ton. And
thank you. Now, I'm just looking through the chat, and if there's any questions, I'll try to answer those. I didn't get a chance to look at the chat while I was talking, but I'll go through them. And if anybody has my email, please feel free to shoot me an email or.
Thank you. We've been monitoring the chat. If other questions come up along the way, we will. And if it's okay with you, we can include your email in the follow-up that we send out to everyone as well. So appreciate that. And
all right. Thanks, everybody.
Thank you, Liz.
Thanks so much.
Thank you, Liz.
Thank you.